Hello there. My name is Jonathan Friedman, and you are listening to the FAQs podcast by EHN Canada. This is a show where we scour the internet for the most frequently asked questions about mental health and addiction and ask an expert for their answers to them. Today, it is my honor and my pleasure to introduce my special guest, Dr. Nick Carleton. Nicholas Carleton is a professor of clinical psychology at the University of Regina, director of the Psychological Trauma and Stress Systems Lab, and a registered clinical psychologist in Saskatchewan. He serves as an active member of several national and international professional associations and as a volunteer research advisor for numerous organizations. He focuses on the mental health of first responders and other public safety personnel. He has published over 270 peer-reviewed articles and book chapters, completed 500 plus national and international conference presentations, and been awarded over $100 million in competitive funding. Wow. Nick, welcome to the show. How are you doing today?
Thanks very much. I'm delighted to be here, and I'm having a really good day so far.
We love to hear it. Before we get into the 5 big questions, can you take a moment to share a bit about yourself and your journey into the field of mental health care?
Well, I guess there's short and long versions of that story, but I guess let's go with the short version of that story. A lot of the work that I have done, really, my very first honors degree was in psychology when I was taking my undergraduate classes, and actually my honors degree research focused on 9/11 and the events that were occurring right around then. And I think for a lot of us, we watched as first responders rushed in where others were rushing back out. And I had the privilege of becoming engaged in a variety of different ways with different first responders who were facing not necessarily challenges of that size and scale, of course, on a regular basis, but who are regularly facing challenges for all of us. I've got friends and family who are either currently serving or have served over the last couple of decades in a variety of different capacities. And so it really becomes quite a personal thing for me to be able to engage with providing them with better systems of support. And by extension, all of the people who choose to serve. It's really a privilege, I think, for anybody who gets to work in this area. These are tremendous people who are putting their lives on the line and their safety on the line for all the rest of us all the time.
Well, thanks for sharing that, Nick. That's awesome. And thank you for all the work you do.
Well, thank you. That's my pleasure.
Now, we're going to get down to the nitty-gritty. Nick, are you ready to dive into the internet's biggest questions around post-traumatic stress disorder, or PTSD?
Sure, let's tackle it.
Let's just start by explaining what PTSD is. I think on social media, a lot of people are like, "Oh, that gave me PTSD," but I think it's a big topic. And how does it manifest in individuals who experience it?
Well, let's put a little bit of historical context around this. So the challenges that we're seeing with what we're currently calling post-traumatic stress disorder are thousands of years old, and they've been recorded in different ways by people for generations and generations. The actual diagnosis that we know today that we're talking about as post-traumatic stress disorder actually didn't come about until 1980. So it's actually relatively new, all things considered. And we've seen differences in the dimensions and the specific elements associated with PTSD over the last 45 years. And I expect we're going to continue to see those elements change in some cases small ways and in some cases large ways. But when we're talking about post-traumatic stress disorder as it stands today, as it's defined, for example, in the DSM-5, we're talking about, first and foremost, something that occurs after someone's exposed to a specific category of events. So if I'm going to be able to meet diagnostic criteria for something like post-traumatic stress disorder, I'm probably going to have been exposed to one or more events that involve death or threatened death, actual or threatened serious injury, or actual or threatened sexual violation. So I can experience any of those things, and those things cover a whole myriad of different potential events that we could be exposed to, from car accidents to assaults to shootings to natural disasters. I can experience those events in a lot of different ways. I can experience those directly myself, so I can be a person who's in a car accident. I can be there witnessing it as it occurs to someone else, so I can watch a car accident occur. I can learn about that event and that event having happened to a close relative or friend. So I can find out that a loved one, for example, was in a very serious car accident that threatened accidental or violent death. Or I can be repeatedly exposed to that event or the details of that event For example, such as a police officer repeatedly hearing details about a child sexual abuse case. So there's a variety of ways that I can actually be exposed to that event. But the first piece of the puzzle is I was exposed to something like that. So you're right. We quite often, I mean, increasingly it's moved into the vernacular where somebody will say, oh, yes, I have PTSD over not having, my favorite diner didn't have my meal and I just can't stop thinking about it, so I have PTSD. Well, you might have a mental health challenge because you're having difficulties with that event, but it's probably not going to be PTSD. So we've got that initial category. After you've got that initial category, then we start talking about different kinds of symptoms that you might experience. So I've been exposed to that kind of an event, and the vast majority of people exposed to that kind of an event tend to recover naturally on their own. But over time, if they're continuing to have difficulties and those difficulties meet a certain set of symptoms, then there's a chance they might be diagnosed with post-traumatic stress disorder, or they might meet criteria to be diagnosed. So there's 4 different symptom clusters that we're going to talk about. And I have to have been experiencing those symptoms, usually in ways that are distressing or impairing, for at least 4 weeks before I would meet criteria for being diagnosed with PTSD.
And for our listeners who may not be familiar with the DSM, a symptom cluster is just a grouping of different symptoms.
Yeah, perfect. Thanks for that, Jonathan. Yeah, that's really all it is. It's not much fancier than that. So those 4 symptom clusters. Let's talk about the first one. The first one is called intrusion, and it has historically been called re-experiencing, and sometimes that's how we think about it. So intrusion occurs when I'm experiencing recurring images, thoughts, dreams, flashbacks that cause distress when I start to think about them. So if we continue with the car accident example, if I'm regularly dreaming about that car accident, if I'm having nightmares where I'm back in the car accident itself, if every time I drive by that same location, I'm reminded quite intrusively about it, I'm thinking heavily about it, I'm prepping, I know I'm coming up on that same space where the car accident has occurred, and it's causing me distress, or it's causing me to engage in different kinds of symptoms like avoiding it. And that brings us to our second symptom cluster. That second symptom cluster is really focused on avoidance symptoms. And some of the avoidance symptoms are probably things that seem pretty intuitive. So I got into a car accident on a specific piece of highway. Now I go out of my way to avoid going to that piece of highway, not just because it might be of high risk, but because I don't want to think about the car accident. And I know that I'll think about the car accident. I know I'll be distressed if I go there. So that's one possible kind of avoidance symptom. The avoidance symptom that I just described, though, this is an overt avoidance symptom. There's actually an interesting set of discourse and discussion happening right now about things called covert avoidance symptoms. And so those might be a set that we need to attend to in a different way. So overt means you're actively watching me avoid going to that space in the car where the car accident occurred. Covert might be, I've got no choice. I'm going to drive down that part of the street, but I'm going to actively find ways to distract myself so that I don't end up thinking about the car accident while I'm doing it. So I'll sing a little song that happens to be an earworm, or I'll listen to music really loudly, or I'll intensely focus on something else as I try and still avoid thinking about the car accident.
It could be like a certain behavior, but the function of that behavior is still avoidance.
That's perfect. Yeah, exactly. So the behavior might be different, but really the end game for me is the same. I'm trying not to think about it. I don't want to have that recurrent image. I don't want to have that intrusive thought image. I don't want to consider it going forward because it causes me distress. The next major cluster is called negative mood, and it's had different names over the years as well. But in this case, really, you're talking about a group of symptoms where someone might feel numb. And so by numb, I mean things like they're not really feeling emotions. They're not feeling happy. They're not feeling sad. They're sort of feeling disconnected. And in some cases, that's associated with another symptom called detachment. So I really don't feel like I'm connected to myself. I feel like I'm not really fitting into my life. I'm not 100% engaged the way that I would like to be. You can also, though, have symptoms of something called anhedonia, which is a fancy word that really means I'm not necessarily feeling sad, but I can't feel happy. So I'm going to my family member's birthday party. I should be ecstatic. I should be excited. I got nothing. I'm not sad. I've just got nothing. And that's a potential problem that's associated with this cluster. And then depression, wherein that one, I think we have a pretty good handle on the idea generally when we use that word colloquially. But so I feel sad. My mood is down. I'm unhappy. I'm having difficulties because I'm unhappy. But it can also be associated with other things that can become more complicated. So being in a daze, a reduction in awareness. You might have seen this. If you've seen somebody being depicted in a movie or a TV show who has PTSD, they might sort of have that 100-yard stare or 1,000-yard stare, as it were, where they're not really paying attention. They're distracted because they're in a daze associated with the symptoms. And that can go all the way up to difficulties with feeling like reality doesn't feel real for some kind of reason. I don't feel really like I'm in my own self, so to speak, using that metaphorically. Those are the negative moods. And so there's a lot of different elements that fall under that cluster. And you don't need to have all of those different elements. You need to have a combination. You could, but you don't need to. You could have a combination of those elements that are interfering. That brings us to our fourth one, and the last symptom cluster. This is changes in arousal and reactivity. We used to refer to this just for a quick note as hyperarousal, but it's not necessarily just hyperarousal. So in this case, we're looking at symptoms involving things like I'm having trouble sleeping. So I'm having trouble falling asleep. I'm having trouble staying asleep. We're looking at things like irritability, though, as well. So something that wouldn't normally bug me, I stub my toe and all of a sudden I'm really angry, or I'm just generally grumpy all the time. I'm not unhappy necessarily, but I'm irritable. I'm angry. I'm frustrated quickly and easily. It could go up to things like self-destructive behavior. It could be associated with me feeling really vigilant all the time. So I've got to be able to see the front door. I've got to be able to check whether I'm safe in my surroundings. I'm having difficulty just being calm and relaxing. And it can include things like exaggerated startle response. So this is one, again, that you quite often see in movies and TV when they're trying to depict somebody with PTSD. A car backfires all of a sudden and the person has a large-scale startle response because it reminds them of a shooting, for example. So if I have all four of those symptom clusters, symptoms from each of those clusters, each of those groups, that intrusion group, that avoidance group, that negative mood group, and that altered reactivity, and arousal group, and I have those for more than 4 weeks, and they're causing me significant distress and impairment, then I might actually meet criteria for PTSD, and a registered licensed mental health professional might provide me with that diagnosis.
That's really interesting. And I actually going to go off script here, and it kind of brought up a different question for me, which is, a lot of those symptoms sound like they could be PTSD, but to somebody who doesn't ask all the questions, they could seem like depression, or it could seem like anxiety. What are some of the tools you use as a clinician when somebody comes into your office, they're talking, and they're just like, I've been really irritable lately, or I've been feeling that anhedonia. They may not come out and say, I experienced a traumatic event, and as a result, I've now experienced anhedonia or this depression. How do you put those things together to get to this PTSD diagnosis?
That's a really good question. So let's really go off script for a second and build off of what you said, because it's possible, for example, that you could have more than one diagnosis at a given time. And that's because some of the different diagnostic categories, so some of the different diagnoses do overlap with each other. Depression is a really good example. It's not uncommon for people to have difficulties with post-traumatic stress disorder and have something called comorbid difficulties, so co-occurring difficulties with major depressive disorder. When we start trying to figure out which disorder might warrant a diagnosis, this is when you talk to clinicians and they have a variety of different skills and tools that they can bring to bear to try and do that. So they could use an unstructured interview, for example, when they start asking questions to try and tease apart what other symptoms you might have and what things might have brought those symptoms to occur. So when did you start feeling these depression symptoms? Was it a month ago, 2 months ago? What was going on around that time? You can also, though, see some clinicians using structured clinical interviews, and there's a variety of those, where as part of meeting you and discussing with you, they're going to go through and they're going to ask a series of very similar questions that help them to identify what diagnostic category might be most appropriate to help you. Now, when it comes down to making a choice, this is where things get a little bit more complicated. In a really ideal world, you're hoping that you're going to have one disorder and one set of symptoms, and the set of symptoms maps perfectly onto the disorder, and everything is great. But human beings tend to be a little bit more fuzzy than that, if you will. So many clinicians will try and essentially use the diagnosis that's going to most effectively cover the bulk of the symptoms that you've got. What's the best fit? And if it really would cover two, they might provide two diagnoses. Now, there's an important little caveat side note here that I hope will be useful for everybody listening, and that is a diagnosis is really a label that is a tool. It's not intended to be something that's punishing, and we hope that it's not something that causes stigma, but for some groups it really can be stigmatizing. But that diagnosis really does help the clinician to take the next step, which is once we know that you've got this diagnosis, we can have a conversation about the kinds of treatments that might help you manage those symptoms. So a really good diagnosis that maps onto a set of symptoms really well helps to inform what we're going to do next in order to help you alleviate those symptoms. And that's part of why we do that. So we've got the symptoms, we've got various ways to get to figuring out what diagnoses might work, and we're doing that because we want to figure out which treatments might be best to help you with the next step.
I love that. And thank you for sharing that. I think that gives like a lot of clarity around that piece. So we have what is PTSD? We have looking at maybe some of the differential diagnosis piece. What comes next? What are some effective treatment options? Like you've done the diagnosis part. What can somebody coming into that office expect next?
So we have for all of the disorders, and there's no disorder that's necessarily better or worse than any other. And so for not all, certainly most of the disorders, we have things called evidence-based treatments. And evidence-based treatments really should be your first line, your first effort to try and address a diagnosed mental health disorder. So there's a variety of different evidence-based treatments that exist right now, and there's a variety of different sources you can go to learn about them. And I'm happy to provide you with a couple of links so that anybody interested can quickly link on those so they're not trying to make notes right now while I'm talking and trying to sort things out. But
we promise they'll be in the show notes after.
Okay, perfect. So for example, there's for post-traumatic stress disorder in particular, you've got treatments that the APA provides descriptions for, and that's the American Psychological Association. And for PTSD, they've got treatments that are strongly recommended because they're evidence-based. So before we talk about what those are, let's maybe just spend a minute and talk about why we want those. There's any number of different ways that you could try and address any number of problems. When we're talking about mental health challenges, though, we really want to be able to provide a solution to somebody or a pathway to a solution that we know is likely to work because we've seen it work a variety of times with a variety of other groups of people. And we've tested it to see that whatever the solution is that we're trying to provide actually fixes the problem that we are applying that solution to. This is just sort of the foundational pieces of evidence. So it's sort of like I might have a headache. I might have a headache, and I might have different ways that I'm going to address that headache. One way might be that I could eat a Smartie. Well, okay, the Smartie might help, but I might also need some kind of medication. How we know that the medication is more likely to help if it's an evidence-based medication, and lots of the over-the-counter ones would be, is because people have run a bunch of trials where they have, for example, hidden whether the medication is a Smartie or if it's the actual medication. And so they've run specialized analyses, building advanced research studies, so that basically they can do a really good test to see whether or not the medication they're giving me is going to be more effective than me just taking a Smartie. Because humans succumb to something called the placebo effect. And so we want to make sure that if we're giving you a treatment, that it's better than the placebo effect in and of itself. And the placebo effect can be quite strong. So APA is one of the groups that keeps a list of the treatments that we believe work because there's been a lot of research evidence by a lot of different groups of people that have come to the same conclusions. So those include things like cognitive behavioral therapy, wherein you're going to focus on relationships between thoughts and feelings and behaviors, and try and focus on current problems, in this case, post-traumatic stress disorder, and how we might change your thoughts, your feelings, or your behaviors to help you experience fewer symptoms. There's another one called cognitive therapy, and cognitive therapy is built on cognitive behavioral therapy, and it can be very much focused on modifying specific elements of your memories of the trauma or how you are engaging with your thought patterns related to the trauma to try and help reduce your symptoms. There's another one called cognitive processing therapy, and that one is also related to cognitive behavioral therapy, where you're trying to change unhelpful beliefs or unhelpful patterns related to the trauma itself. And there's one called prolonged exposure therapy. Prolonged exposure therapy is, again, a specific type of cognitive behavioral therapy where it's trying to address the symptoms by addressing one of the big challenges related to symptoms, and that's avoidance. So a lot of the research so far has shown that the more we try and avoid something, the more problematic that something can be, particularly if we're talking about something like PTSD. And the avoidance in and of itself becomes a problem. So let me give you an example. And by the way, the therapist might choose to engage in focusing on avoidance in any of these therapies. But if I told you, don't think about a pink elephant, I want you to make sure that you do not think about a pink elephant at all right now. Well, what I've just done is primed you to think about a pink elephant.
And I'm thinking about them right now.
That's right. And you probably haven't imagined, right? I imagined the movie Fantasia and they're dancing, and now we've got nothing but pink elephants.
You got it.
So now we have a problem. And part of that problem is actually built right into how we think. So if you imagine your mind, I'm going to oversimplify things by quite a bit here, but imagine your mind for a second. I want you to not think about a pink elephant, and you're going to actively try to not think about the pink elephant. In order to do that, you've got to bring to mind the pink elephant. And then as thoughts come to your mind, as other things come up, as things you look outside in your world, or as you start imagining, remembering things, you're constantly going, well, is this a pink elephant? Yes. Okay, stop thinking about that. Is this a pink elephant? No, this is a green kangaroo. Okay, the green kangaroo is good. But the whole time, you're having to keep the pink elephant in your mind in order to know which thoughts you shouldn't be thinking. This creates a system-level challenge for us inside ourselves. Prolonged exposure, on the other hand, takes a different approach, and it says you're having trouble with the pink elephant. So let's talk about what the problems are with the pink elephant, and then could we actually try to think about a pink elephant for a little while? And then maybe we can look at a picture of a pink elephant, and then maybe we can slowly together, gradually increase how much time you're going to spend thinking about that pink elephant, with the plan being that eventually your symptoms, when you automatically think of the pink elephant, when it pops up, when it intrudes as part of that intrusion cluster, comes to mind, it's not going to cause the same distress that it had caused before. So these are really four of the primary treatments we have. We also have things like EMDR, which is eye movement desensitization and reprocessing therapy, which focuses patients on thinking about the trauma and bringing it to mind while also engaging in other activities like bilateral stimulation. We have narrative exposure therapy that really helps you build a coherent life narrative that helps you to contextualize the trauma in the rest of your life so that it's not the only thing in your life, it's part of your life. There's also brief eclectic psychotherapy, which involves elements of cognitive behavioral therapy and a psychodynamic approach where it's going to focus on emotions and emphasizing relationships between the patient and the therapist. And then we have medications. And there's a variety of different medications that may be used to provide support for somebody who's seeking treatment for PTSD. So those are some of the primary treatments that are available that are evidence-based treatments. And if you're working with a registered licensed clinician, that person can certainly be very helpful in selecting different treatments. Evidence-based treatments don't always work for everybody all the time. Sometimes you might need to try one or two different evidence-based treatments or one or two different combinations of a therapist and an evidence-based treatment before you get the right fit for you. But they should always be the first line that we start with.
And that's really up to that registered clinician who's there to understand the problem with you and help to guide through all of these different types of treatment options and modalities to see where is that best fit.
Absolutely. And everybody's different. We're all still unique. So what might be a best fit for me might not be a best fit for you. But that's why you want that relationship with that registered clinician, so that you can build together. So the clinician can go, I'm not sure that's a great fit for you. Let's try this one instead. And if that doesn't work, we can try one of the other evidence-based treatments as well.
Totally makes sense. And I try and read a lot of emerging technologies about a lot of emerging therapies. And there's been this big push into sort of virtual reality and exposure. How do we start to learn about, to engage in these emerging therapies or technologies or approaches in this kind of mental health support?
As a researcher myself, this is one of my favorite questions because it's part of what we do to create evidence-based treatments. And so the first thing, I think one of the important first pieces is that a lot of the emerging therapies that are coming out are quite often building off of the existing research and the existing literature base, where in some cases they're trying to find new and innovative ways to build on success. And I like to think that makes sense to everybody. So, for example, if exposure-based treatments are successful, which the evidence suggests they are, it can be difficult, though, sometimes for me to do exposures because sometimes it's hard for us to recreate or reimagine as vividly as we might hope the thing that's causing us a problem. Well, virtual reality provides us with a whole new set of alternatives there. It provides us with a brand new set of options. So virtual reality is building off of the same fundamental principles in many cases of exposure therapy that we would use and that we have used before, but now it gives us a new tool. And in that way, it's exciting. So, for example, if you'd ever seen the Next Generation Star Trek series, there's something called a holodeck where you can walk in and it creates an uber virtual reality for you. Well, if somebody's having difficulties with something like PTSD, that would potentially be a really amazing way for us to help work with them together, because then the person having difficulties and the therapist can walk literally into the experience together and work through that experience. That's a possibility going forward. And so that provides us one set of possible tools. Now, different people are trying different ways to use virtual reality and technology. And what we're seeing is they're creating research studies in order to figure out what's the best combination. Because maybe actually a holodeck is not great. So I think the holodeck would be a fabulous idea and that would be wonderful, but maybe it's not. Maybe that's too much all at once. Maybe that immersion is actually going to overwhelm somebody and cause more harm than good. So different groups all across the world, certainly in North America and in places like Australia and the UK, are working on this, and they're creating different designs. So what if we do it just on a screen? What if we put goggles on? And then how does adding that technology add benefits above and beyond what we already have for standard therapy? So we might, for example, do prolonged exposure in this treatment. We might randomly assign people. So we get 100 people who have PTSD, and we randomly assign half of them to have prolonged exposure, which we already know is an evidence-based treatment, and they don't get the virtual reality. But the other half get randomly assigned, and they do get the virtual reality. Does the group that got the virtual reality do better than the group that got prolonged exposure? And better could mean different things. Do they experience more symptom reductions? Do they experience faster symptom reductions? Are they more likely to engage? Are they less likely to engage? So somebody who has post-traumatic stress disorder, it actually might be off-putting for them to use the virtual reality. Because I'm going to say to you, well, Jonathan, I understand that you've got post-traumatic stress disorder challenges because of this event. Let's put the virtual reality helmet on you. Well, that might be too much for you. Now, you could also, though, add virtual reality at different parts. So I might say, well, let's start by you just talking to me about it. Let's start by you and then move on to imagining it, and we'll work your way up to virtual reality. So there's so many combinations.
To exposure therapy.
Yeah. Oh, I love that. Boy, you should coin that somewhere there, John. That in and of itself is good.
It's here forever now.
Okay. But that's perfect. And that's also what's so interesting about research is that there's so many different ways we could combine those puzzles. And over enough time, you're going to get enough different researchers combining those different possibilities in different ways that we're going to have enough studies that come out that you'll get a research team that will run a set of specialized statistical analyses to create something called a meta-analysis. And that meta-analysis will help us to understand whether or not virtual reality, for example, is meaningfully increasing this such that we should make it a standard evidence-based treatment. Do we want to invest in this? Is this something we want to train new clinicians in? Is it enough of an improvement that we're going to invest in the technology? And that's how we build actually all new treatments when we're building evidence-based treatments.
That's super cool, and sounds like there's a lot of new, cool, interesting ways that researchers are going about solving this problem and starting to approach how to reduce symptoms.
Yeah, and it's exciting. It's exciting times because researchers can communicate in ways they've never been able to before. We're able to share information certainly faster than 45 years ago, and we can do more and more together to build solutions that can actually help people.
I love that. Moving a little bit away from the holodeck and sort of the technology piece of it, how important is community support in the healing process for those with PTSD? What role can or do family, friends, loved ones, and community play?
I think they can play a tremendously powerful role. So there's a lot of research evidence that we've got that suggests, for example, people who are in positive spousal relationships are more likely to be resilient. They're less likely to experience mental health challenges. And that should make a certain amount of sense. We're social beings. And so when we feel like we've got a social support system that's helping us, that social support system does exactly that. It supports us. It helps to protect us. And when we're talking about the healing process, when we need to recover from something, our friends, our family members, our spouses, our children in some cases, they can all be huge, huge benefits for us going forward, because treatment and healing from things like post-traumatic stress disorder can be very challenging. It's not easy. I wish there was a magic button, but there's no magic button, at least not yet. And so the work that we have to do as part of the evidence-based therapies, the effort that we need to put in to change what's going on in our lives is substantial. And so if we have a spouse or a social support system, that can make a huge set of gains for us, especially if we have a system that's not stigmatizing. So if our workplace is psychologically safe, if we're not in a workplace that is intentionally anti-mental health for some reason, or is particularly challenging for us for whatever reason with respect to our mental health injury, that can be helpful. So all those groups coming together, they make a big difference. It's part of what helps with things like peer support, and part of what helps with things like community-based programming, or in some cases group-based therapies. That social connection can be a huge part of the puzzle for a lot of people.
That's really interesting. Like, what are some things that like I or people listening can take away to start creating some of that psychological safety and stigma reduction in their own workplaces, in their own relationships, in the community?
I think one of the first things that we can all do is start by recognizing that there is still stigma with respect to mental health. And there's 100 plus years of stigma with respect to mental health. In fact, post-traumatic stress disorder has been particularly stigmatized. I'm not saying that they all haven't been, but it's been particularly stigmatized because of its relationship with things like persons who provide service. So military, first responders, public safety personnel. Because people who are having mental health difficulties is a function of what we as their community members ask them to do for us, to serve in the military, to serve on the front lines here in a variety of different public safety capacities. They were exposed to those same kinds of events that we discussed at the beginning today. And we asked them to be exposed to not a few of them, but to hundreds, thousands. So by recognizing that we're asking them to do something that could be injurious and recognizing that there's stigma, that starts already to change the conversation. I think it also helps if we are open with each other and have these kinds of mental health conversations. We have to be free to talk about mental health, and we have to be free to talk about it as freely as we would physical health. And part of this just becomes practice. So just like your exposure to exposure therapy, we need exposure to conversations about mental health. And it's going to be awkward at first in a lot of cases, but we need to talk about it. Because if I broke my leg, everybody would very quickly rush to sign my cast. Well, I don't know if they still would. I imagine they'd sign my cast, and everybody would say, yeah, you're okay, Nick. Oh, sorry, Nick. Yeah, you can't quite jump up today because you've got a cast on your leg. I'll help you, and I'll support your recovery. We've got to make that change, and we've got to make it intentionally. And I think we're seeing some of that, but we've got a long way to go yet.
Love that. So, Nick, it's been an absolute honor and pleasure to have you on the show. If you're to leave listeners with one piece of advice around starting their own journey with mental health, maybe their own journey around their trauma recovery, what would you tell them?
Well, I'd say take a look at the couple of links that you're going to make available to everybody that I'll pass on to you. Start there. Start reading. Read links like that. Go to safe spaces, places where you know you're getting evidence-based information, because there's a lot of misinformation online right now, and you really want to make sure that you're getting the best possible care. Be open to those kinds of readings, and wherever possible, reach out and get help from an evidence-based care provider, somebody who's registered and is specialized in providing the kinds of supports that you need. Because the sooner you reach out, mental health care works very much like physical health care, Jonathan. The sooner you reach out to get help, quite often, the better off everybody's going to be. We should treat our mental health as well as we treat our dental health. Let's get help early and as often as we need from care providers who know what they're doing. That's, I think, the best thing we can tell everybody to do.
Well, then, Nick, thank you so much for being on the show. And listeners, to listen to even more episodes of the 5 Facts podcast, you can check it out on your favorite streaming platforms, Spotify, Apple Podcasts, we're everywhere. And to learn more about EHN Canada and the work we do, check out ehnccanada.com. Thank you so much, everybody. Thank you, Nick, and we'll see you all next time.